Sure. Sir, shall we start now?
Please, Maitri.
Okay. Yes. Namaste, everyone. Akhanda Mandalakaram Vyaptam Yena Characharam Tatpadam Darshitam Yena Tasmai Shri Guruve Namaha. On behalf of Journal Club of Journal of Ayurveda and Integrative Medicine, I, Dr. Maitri, would like to welcome all the expert panelists who have joined, our JM club members, all the teaching faculties, PG and PhD scholars who have joined the session today. Today is going to be the 19th session of Journal Club organized by Journal of Ayurveda and Integrative Medicine. Journal Club is a forum to appraise and critique the research papers which are already published and also evaluating the research for utilization in the clinical practice involving not only the mere studying of it, but also debating on it, analyzing it, and understanding its 360-degree implications and outcomes. Overall goal is to formulate a general evaluation of merits and study and to evaluate its applicability in the clinical practice. So for the session, we have our panel of experts where Dr. Ashok Vaidya sir, who will be joining the session in few minutes. Research Director, Kasturba Health Society, ICMR Advanced Center for Reverse Pharmacology in Traditional Medicine, Mumbai. We also have Dr. Ramakrishna Shenoi sir. Dr. Ramakrishna Shenoi sir has done his BDS and MDS from Government Dental College, Nagpur. He is currently the Vice Dean and Head of Department of VSPM Dental College, Nagpur. He has a vast teaching experience of 28 years and is a PG and PhD guide. Dr. Shenoi has more than 60 publications in reputed journals and also chapter contribution in various books to his credit. He was an executive member of national and state ASOCIN, that is Oral Maxillofacial Surgeon Association, and also he's president of the study group of CIOMS. Our next expert speaker will be Dr. Samir. Dr. Samir Krishnakant Jadhav, BDS, MDS, and Master in Oral Laser Application. He is a professor and postgraduate guide in Department of Conservative Dentistry and Endodontics in MA Rangoonwala College of Dental Sciences, Pune. Also, we have the author herself who has joined today as a panelist, author of the paper to be discussed today, Dr. Pallavi Menon. She is the assistant professor in Department of Periodontics in Amrita School of Dentistry, Kerala. So we would like to extend our heartiest welcome to all the expert panelists who have joined us today. And for today's presentation, we have Dr. Reshma Sanil, third year postgraduate scholar in the Department of Shalakya Tantra, Amrita School of Ayurveda, for the presentation. With due respect and with due permission from the expert panelist and the JM Club members, I would like to invite Dr. Reshma Sanil to start her presentation. Dr. Reshma.
Thank you, Dr. Maitri, for the presentation. And a wonderful good afternoon and a warm welcome to JMT members, the panelists, the conveners, guests, and expert panelist, Dr. Ramakrishna, Professor and Head of the Department of Oral Maxillofacial Surgery, VSPM Dental College, and my gurus. I take privilege to invite my colleagues and my friends, and again, the esteemed audience, for this wonderful meetup where we're discussing a scientific paper exploring the analgesic effects of natural drug, dry ginger powder. I'm also honored to introduce myself. I'm Dr. Reshma Sanil, PG Scholar for the Department of Head and Neck, Amrita School of Ayurveda. Sorry, my slide is not moving. This is the first look at a glance. It talks about the title of the paper, effectiveness of ginger on pain following periodontal surgery. Here we're talking about open flap debridement. It's a randomized crossover design. With a crossover design, it's a clinical trial. And the authors are Pallavi Menon, Jayachandran, and the rest of the screen up here. I, in fact, had the privilege to speak to Dr. Pallavi Menon, who spoke at large about how she conducted the trial. And they are affiliated, the authors affiliated to Department of Periodontics from Amrita School of Dentistry and of Manipal Academy. Now, first things first, we're talking about crossover trial. So I'll just run you through the importance of crossover trial. This is actually, what I'm dealing here with is a 2-into-2 design, which is 2 treatment periods in 2 groups. So we have 2 groups, one with intervention drug and the other undergoing reference drug. After period of treatment, they have a washout period, and both the groups are swapped and the medicines are reversed. So now this has certain prerequisites. Before we even jump into the main session, we need to know what exactly are the prerequisites of a crossover trial. Now, the condition needs to be stable. That means it should not change. It should not change with period. It should not time temporarily, change with time. And it should not have carryover effect, which means the first drug should not influence the second drug. And it should not have a period effect, that is temporarily with time. The condition should not change so that it can alter. So this is actually, these two needs to be adjusted, if any. Now, in a crossover trial, the importance of crossover trial rather is that a patient acts as his own control. And for this particular reason, the statistics are always paired. Now, coming to the paper that we are dealing here today, it's a crossover trial, as I said. We're dealing with a surgery called open flap debridement, where the maxillary quadrant, or put in other words, the upper jaw is taken and divided into 2 quadrants, right and left, where one, after surgery, for post-surgical pain rather, the first group is given dry ginger and the second group is given ibuprofen. And after a period of treatment period, after a period of washout rather, the groups are swapped and the medicine again is, as I said, is reversed. The first group which had taken dry ginger powder would be swapped for ibuprofen and vice versa. Now here the stable condition is postoperative pain in diagnosed patients with chronic periodontitis in undergoing open flap debridement. Here the washout period is 3 days. Now this is a quick look at the paper. I will not jump into the details as we are going to emphasis in each and every point as we see through it. You can just, I recommend you take a glance at it. Coming to the background, the author presents a very beautiful, highly referenced background for her study. Here we're talking about post-operative pain in patients undergoing or who have underwent open flap debridement. Here the pain is mild to moderate. Ibuprofen usage is commonly seen in post-operative pain care. Now the contraindications are varied and it involves gastrointestinal, renal and CVDs with references. And she also, or the author, the scientist also presents here wonderful references for ginger with proven anti-inflammatory and analgesic activities. And she substitutes an ibuprofen with ginger, dry ginger powder, and she considered it to be a potential substitute with high references again stating her rationale. Now, she also, the author also proceeds to talk about active gingerols like paradol, zinzerol, and shogols. Again, highly referenced papers with hypotensive, antitussive, analgesic, and antipyretic activities of 6-shogol and 6-gingerol. Again, when animal was treated with dry ginger powder orally, the acute inflammation was receding. So this also has been stated as one of the facts or rationale for her study. And again, ginger being used for many cases in osteoarthritis as an analgesic. So again, the author says that the study could be very novel for pain management after periodontal surgery. Coming to the methods. The objective is to compare the effectiveness of ibuprofen and dry ginger powder on pain and gingival inflammation following open flap debridement. In other words, she's substituting as a substitute medication a quid pro quo of ibuprofen as ginger dry powder. Patient data is number of patients involved, 10, 30 to 60 age group, male and female. The venue is outpatient section of Department of Periodontics, Amrita School of Dentistry. Patients who have been posted for full mouth open flap debridement after informed consent. The inclusion criteria here is patients with 20 natural teeth, chronic generalized periodontitis greater than 30%, at least 4 posterior teeth, and with a pocket depth or probing depth of greater than 5 mm. The exclusion criteria is systemic diseases, acute gingival and periodontal diseases, certain procedures requiring regeneration techniques, patients who have had NSAIDs for the last or before 3 months prior to the trial, allergies, peptic ulcers, and in pregnancy, lactation, and patients with tobacco use. Now, this study design is simple. It's actually based on a famous dental pain model. The patients who are posted for open full mouth debridement, open flap debridement, are basically assessed with the previous slide. I've mentioned the exclusion and inclusion criteria. So they're basically assessed with this, and the study sample is taken. They undergo a full mouth scaling and root planing, after which the patient will be assessed for baseline pain and gingival status. They proceed to take open flap debridement of the first quadrant, either it can be left or right. And again, we have 2 arms, group A, group B, or the active arm and the reference arm. One group undergoing ginger powder, the other undergoing the reference drug, ibuprofen. And after the surgery, the pain will be assessed for the first 8 hours. Every hour, the pain will be assessed. And following 2 days, they are going to be assessed in the morning and the evening. So this will be done for both the groups. Now, the third visit, again, after 1 week, usually, we have collected the baseline measurement for gingival status. So 7 days gingival status will be assessed. And after which, for the second quadrant, before the second quadrant surgery, a 3 days washout period is given for the second quadrant. And then the process is repeated. The same way, same thing from the beginning, from the first visit, how they have proceeded to the third visit, same thing is repeated, but only thing, the patients are crossed over, or in simple words, the medicine is swapped, and the same thing is dealt again. And the fourth visit, again, after a week, the gingival status is assessed. And finally, the analysis is collected. Now, this is the identifying information, as I said earlier. The randomization here is the quadrants, maxillary quadrants are randomized on lottery method. It is a single blinded study. It is not patient blinded. Let me put it clear. It is actually outcome assessor blinding. That is, a person who's actually collecting the outcome is blinded. Now, the second thing that we are talking about is the drug. Now, the drugs used are dry ginger powder or ginger capsule from Himalaya. It's actually a ginger tablet. It is the type, I'll be doing that later, but it's actually a tablet that comes. And we also have ibuprofen 400, Brufen 400 is trademark, and both given at a dosage of 400 mg. The rescue medication, if in case required, is acetaminophen 500 mg, 4th hourly. The procedure is maxillary quadrant OFD. 2% lignocaine was used, and the maximum effect is 120 minutes of lignocaine. Data analysis will be done on visual and log scale, 10-point scale, first 8th hourly for every hour for the next 2 days, morning and evening. A modified gingival index for gingival inflammation, Lobin 1986, baseline and 1 week measurement is taken, and Mann-Whitney U test is used for the analysis of the VAS score, and p-value was set at 0.05. Now the results, 10 patients, that is all 10 patients completed study, out of which 4 were male and 6 were female. There was no fallout, no allergy recorded, and there was no need for any rescue medication, since probably the post-operative pain is mild to moderate. Procedure was uneventful, same amount of local anesthesia was used, and the procedure was completed with the same duration. Visual and log scale was analyzed for the only first day, since the next 2 days it was not very significant, and for every hour till the 7th hour, ginger was comparable to ibuprofen. That means the statistics was not significant, and ibuprofen became significant at the 8th hour. That is, p-value was recorded at 0.04. Now, modified gingival index for post-surgical gingival inflammation, ginger was comparable to ibuprofen. The comparison you can see in the chart. At the 8th hour, you see that there has been a drastic change. So at 8th hour, ginger was less effective than ibuprofen. Otherwise, still 7th hour, dry ginger powder was very, very effective. Now, comparison of mean scores, we find that p-value has increased at 0.04 at the 8th hour. And this is, again, ibuprofen, MGI scores, ibuprofen and ginger. You find that the p-value is 0.8. So it means the ginger powder was comparable to ibuprofen groups. Discussions. The author presents very important papers for enhancing our discussion details. So here we have 3 papers that needs special mention. It's Vidal et al. 2000. He talks in his paper that the team talks about ibuprofen and ginger on pain was not significantly different, which means both were comparable. Now, Raiti et al. In 2017 talks about ibuprofen in post-surgical pain model after third molar surgery, mandibular third molar surgery. It was very, very effective. Now, Terry et al. Is a systematic review of 2011. Ginger components may decrease the pain perception in conditions such as osteoarthritis. Now, from this trial, we understand pain score differences for the first 7 hours after open flap debridement, not of statistical significance, meaning that ginger powder was comparable to ibuprofen. Now, again, discussions. The author talks about visual analog scale, p-value at 0.04 at the 8th hour, modified gingival index, ginger on post-surgical gingival inflammation. It is similar like ibuprofen. Now, the limitations, the scientists are also present the limitations actually. The sample was quite small because it involved 10 patients, although it is a pilot study, and proceeds to talk about how single blindedness could be a constraint, and there was no drug concealment, no measures of specific inflammatory mediators were taken. So these are told as limitations of the study by the author. And the conclusions here given after the trial is dry ginger powder is as effective as ibuprofen in treating post-operative pain after oral flap debridement. When NSAIDs are contraindicated, dry ginger powder may be used as an alternative, and blinding is compromised here. Effect of ginger extracts on specific inflammatory mediators needs to be warranted, as again stated in the conclusion. So this is about the paper and an outlook. And with this backdrop, we'll go on to do the appraisal of paper. In terms of quality, I find that these are certainly my comments, and it is understood that 19 out of 25 guideline requirements are followed. The guideline requirement here again means I'm talking about consort guidelines in terms of crossover studies. And the literature was, certainly it was dealt with high quality references, and the language and outlook looked perfectly scientific with uninterrupted flow. Replicability is quite possible from the details that has been given by the investigators, and it is certainly, it can be, it is compliant with ICH guidelines for somatic acute pain in this case, and it is pain trial also compliant. Now, coming to subject matters about the appraisal, evidence-based scientific rationale was found throughout the paper, and the study design is an established one, so it does not need further evaluations of that particular study design. And again, analysis the determination to complete, and the analysis of the knowledge, certainly the analysis of the study design was in depth, so that they could know how to proceed with executing the trial to its completion. So willingness to accept limitations, the audacity that the author presents here, and apparently, ostensibly, it's actually just become ITT analysis. Now, comments on the title, what we have and what could have been made, or how could be made better. So we have ginger, we have intervention, we have the outcome, that is pain, and the trial is identified as randomized crossover clinical trial. It's very mandatory that the trial is identified as a crossover trial as per the consort guidelines. And this is what we are required, we see in the paper. And now we'll proceed to see what else could have made the title much more rigorous. Now we come to the basic when you say the PICO or PICOT details, we find that the comparator, that is ginger, is mentioned, but it is against ibuprofen. The comparator is not mentioned. That is, ibuprofen is not mentioned. Intervention is mentioned, but the comparator is not mentioned. Now, again, as I mentioned earlier, it talks about single blindedness of the study, where indirectly we think that it could be patient blinded. So single blindedness does not necessarily mean, the assessor outcome, assessor blinding. So the title could have mentioned open label to make it more evident that it was not patient blinded. Now, the quality of reporting, the abstract. What was available in the abstract is title, population, intervention, objective, outcome, results, outcome, and conclusion. But what is expected out of an abstract is that the trial period needs to be mentioned. The source of data, the randomization technique, the blinding, and number of randomized recruitment dates, number of patients analyzed, the harms, if any, trial registration and funding, all are required to be present in the abstract. Now, coming to the background, the author presents a fantastic background, as I mentioned earlier, of 20 main papers. That is, papers on pain have been 3, NSAIDs totally 5, out of which ibuprofen 4, and they are based on clinical trials. And now we also have a reference drug background paper stating the contraindications. And our background literature on the interventional drug is, again, 11 main papers, out of which phytochemical studies are 4, in vitro studies 2, animal studies 3, and clinical study 2. Now, again, what could have been better? How the paper could have been fantastic if the author had, in fact, described about dental pain model, which is very important. The whole study is based on this dental pain model, and it's obviously it is clear that we see that in the paper. But again, it could have been made more prominent with the references where it actually started. Now, again, the references that the author gives here is certainly of acute pain, that is muscle pain here after exercise or exercise-induced muscle pain. But the activity of ginger powder, dry ginger powder, starts around 24 hours to 48 hours, and that's too with 2 grams per day. So these kind of references can be mentioned along with how it is not, or how it cannot be extrapolated into our trial, and how far it can be, or as a shortcoming to the current trial. The references could sometimes not be matched with the current trial, but it need not be, certainly it need not be avoided, but again, it could have been written down by the author, these the particular things that the paper talks about. And coming to pain severity, duration, emotional awareness, expression, and pain processing, all this are the various spectrum of pain. Here we are talking only about pain intensity. So these kind of things needs mentioning in the background. And again, pain during rest and dynamics. We are talking about pain during rest and dynamics. So for example, the patient moves jaw. So any kind of movement creating pain, all this can also be recorded simultaneously when you're talking about a pain trial. Now, again, when we read through the background, we find that ginger has been quoted as a pain reliever, an analgesic from Ayurvedic texts and Chinese texts without any references. I would like to say here that Madhrim Nigandu 7/7 talks about ginger as Shulanut, and if you see the meaning of Shula in Monia Williams Sanskrit dictionary, we find that it is actually sharp or acute pain. Acute pain references in this background were minimal, and the paper that we finally, the previous slide, the author mentioned about Glidol et al. In 2000. The differences here, that is the difference between placebo and ginger extract, was found only in exploratory data analysis. It was not actually evident in the main statistical analysis. Now, ginger being a vanillin agonist, receptor agonist, takes a major, it is a pointer to stating ginger as an analgesic. So this particular point in this paper, Terrier et al. Actually is highlighted, but unfortunately this background was not stated in this paper. It could have been fantastic if the author had written that. Now, preclinical safety data could have been discussed for ginger. Methods, coming to methods again, the trial design, that is acute dental pain model in terms of somatic pain could have been designed, could have been put as the word in the methods, that the design that they have followed. And coming to the period, it's actually 2:2 period, that is 2 treatment groups in 2 treatment period and 2 groups. Allocation ratio here is 1:1, that is 10 patients undergo first treatment group, and the second part is also 10 patients. So the allocation ratio is 1:1. And 8 selection criteria could have been mentioned. Carryover effect of dry ginger powder, if any, could have been discussed a priori. And again, as I stated earlier, pain narrative, that is pain experience of the patient, it could have been much more robust if the author could have included scales like Likert scale, pain diaries, and numerical rating scales for illiterates. Now, we also have something called clinical attachment loss, radiographic bone loss, gingival recession range. These could have been discussed by the author to understand whether the first quadrant is homogeneous with the second quadrant. This is actually from a study where this is a similar study where they're discussing the clinical attachment loss at surgical sites in the ibuprofen group ranged from. So you can see that they also discuss about recession at the sites, and they also talk about radiographic bone loss when they are comparing ibuprofen with another acetaminophen caffeine group. Actually. So this could have been included in this study also. Now, exclusion criteria, when you talk about exclusion criteria, we find that prolonged surgery, post-operative infection, fever, literacy status could have been excluded, or could have been more, the author could have stated how long or for how much, or the status of literacy, etc., all could have been added in the methods. Again, coming to methods, in terms of dry ginger powder dosage, frequency, and the form selection, the rationale of timing, the dosage, all these could have been taken from traditional Ayurvedic or Chinese medicine, as the author states. Now, the sample size rule of thumb is 12 for pilot study, or if it is a crossover study, a mainstream crossover study, the sample size certainly depends on the within participant variability. Here, the sample size was 10. It could have been increased to 2 more and improve the weightage of the paper. Now, the sampling is mentioned, is not mentioned. It is sequential sampling or non-probability sampling here. Allocation, concealment, and implementation is not discussed here. And form, as I mentioned earlier, when I spoke to the author herself, she mentioned that was a typo where capsules were mentioned when that was actually tablets. Again, availability, she mentioned that the dosage was due to availability of the drug, and a similar availability. For example, ibuprofen was available in 400 mg, and ginger tablet was also available at 400 mg. So she had taken that, the feasibility of the medicine, applying medicine is one thing which determines the conduction of research itself. So because of that, she has taken that. And statistician actually, in fact, she thought that the statistician, or she found that the statistician mentioning 10 could be enough for running the sample. Now, coming to blinding, the gold standard is double blinded, where here it was single blinded. Now, this when you design a study chart, there is a need for mentioning the duration, the days, first day, second day, and so on. And coming to the population of the study, we also have chronic periodontitis. The author is mentioning about chronic periodontitis, generalized, but not obviously in terms of its severity, whether it is early, severe, progressive. All this could have been, it could have been mentioned to replicate the study. Now, again, prophylactic analgesics and antibiotic, if it was used or if it was to be used, could have been discussed. Surgery type and procedure design, all this could have been used. Now, evaluation of healing time within periods a priori, again, could have been discussed. Here, the golden, as I mentioned earlier, because the principal investigator and the statistician were both blind, in fact, but it had not come in the paper. And moderately, after speaking to the author, I understand the group was moderately severe, patients diagnosed with moderately severe chronic periodontitis. The surgery type was actually, the procedure involved Kirkland design. Again, during procedure, due to any pathomorphological situation, individual teeth may require combined surgical procedure after visualization. Was it considered to be excluded? Is another question that arises when you read the paper. Starting from incision to wound closure, procedures may vary according to patient gingival counter thickness, etc. Now, again, contraindications for this technique, if any, or none, could have been discussed by the author. Post-operative protocol like antibiotics, mouthwash, ice packs, all this, whether it was to be given or not, can also be discussed under methods. The recruitment rates, baseline data, that is descriptive statistics, could have made the paper much more fantastic. Now, pairing of data is very important here. We're talking about a mandatory U test, which involves independent sample testing. Here, pairing of data is important. So again, as a part of pairing of data, Wilcoxon sign rank test could have been used. Now, again, visual and log scale has been mentioned, 10-point scale has been mentioned. Again, it could have been mentioned with certain descriptors like the alignment, whether it's horizontal alignment or vertical alignment, with or without descriptors, etc. For example, if you see this, here it contains a horizontal 10 centimeter indicated. Person marks numbers from 0 to 10 on the intensity of pain. 0 shows no pain and number 10 illustrates, so on. An MGI scoring system, again, the score ranges could have be mentioned. Adverse events, if any, how was it to be collected, could have been discussed in the methods. Coming to results, the flow diagram. Usually results have a flow diagram which includes losses and exclusion, the recruitment dates along with the trial end. This was currently not available in the paper. Baseline measurements like pain, others like oral hygiene index, bleeding on probing and literacy status needed discussion if that was really possible in patients, at least in the baseline, to understand the homogeneous situation, as I mentioned earlier. Now, consort guidelines certainly talks about pair data. Here, Wilcoxon sign rank test for VAS and paired t-test for MGA could have been better. For visual and log scale, if it wasn't converted to ratio, for example, both the measurements could have been easier using paired t-test. Now, in the results, no dropout. So apparently we understand that it has followed ITT principle or analysis principle. Now, there was a typo, as I mentioned earlier. This is in reference to the design, where the design we find that first 8 hours after surgery and twice daily on the following 2 days. And we find in the description that the first 8 hours after surgery and the following next 2 days. So this is kind of, could be understood as a typo. Now coming to pain modulators, we have response bias. We have reactive effect. If the patient has undergone a surgery before and had taken a painkiller, the second similar surgery could have a reactive effect where the patient's pain may or may not be the same as experienced in the beginning. Now we have pain measurement at rest and dynamics, and diet. Again, diet is an important confounding factor, especially when things like dry ginger powder is considered. Now the operative trauma, the amount of operative trauma the patient undergoes, even if in case of the same surgeon, here we have not understood from the paper whether it is the same surgeon, but after speaking to the author, I understand the surgery was not performed by the same author, giving rise to this particular confounding factor, the operative trauma, the changes during any kind of changes, the technique, the method, or anything that changes during the operation could in fact show differences in the pain recording. Now, having female patients in the group, we should certainly take care of menstrual cycle, because again, menstrual cycle and pain are certainly or inversely proportional to each other. So we can at least find that there could be any changes relative to pain and menstrual cycle. There are papers stating the same, as I mentioned. And then again, emotional certainly awareness, expression, all these are emotionally, it is together, it is linked together. And for example, distress, if a patient was in distress and any kind of anxiousness could have made the pain value, then visual and log scale go different. Now, again, pain diaries could be a wonderful thing where the patient may present exactly what he's undergoing and different kinds of things that we can understand from the pain diaries, and certainly could have been included in the paper. Hawthorne effect is one thing that most of we as researchers know how much Hawthorne effect has a role in pain. Now, coming to discussion of ginger, we find that this is something very important, that is greater than 50 mg per kg was usually gave actual results in trials if it was given orally. That is, we at least have to give greater than 50 mg per kg. Now, API states that 1 to 2 grams per day is enough. Again, weight of active components in different geographical locations vary. This is one particular thing that can be discussed when the author was talking about dry ginger powder. Now, plasma 6 shower gall, 6, 8, 10 gingerol, all this actually the half-life, when you see the half-life actually, it is certainly depending on these particular components that the half-life was set. Now, assumption of this is actually with the components 10 gingerol, that is 2.1 2.1 hours and 6 Shogol 1.3 hours. This was taken as the half-life. And again, the ginger, when you talk about dry ginger powder, less than 1 gram per day orally was not significant. And the author here states that, in this paper states that the immediate action of dry ginger was very, very unlikely. Such things could have been included in the discussion because, again, there are controversial papers and that has to be brought into the discussion part to understand it in its entirety. Form, dosing, time of onset, time of duration of action, interaction, contraindication, all these need to be discussed in the paper. Now, again, we know that ginger has antiplatelet effect, and sometimes patients have also undergone GI upset. So what would be the management? How is it seen? What are the things actually the patients present with and how it is to be managed? All this can also be discussed. Possibility of carryover effects are discussed in the paper. Here we found that when the paper was discussed in terms of, as a parallel group, they found that explorative analysis found out that ginger was effective. But when they did the statistical analysis, ginger was not as significant as the placebo. Food-derived supplements, as I stated earlier, even chewing a ginger candy could actually overdose the herb. Concomitant drug, any antibiotic given along with ginger could be a confounding factor. For example, we see metronidazole, toxicity can happen with metronidazole if ginger was given, or because the bioavailability increases with ginger of metronidazole. So these kind of things could have also been discussed because the drug contains more than 400 compounds and standardization of contents is critically lacking. All this can be actually seen as only a backdrop, and certainly the paper should be appreciated because of all these things critically lacking. I suppose we can overlook all these points. Now coming to this is what I'm talking about. Here they did not find any difference between placebo and ginger when they did a crossover. But when they went to perform a parallel group study in the first treatment period, they found a drastic change with ginger powder. So that is why the author here talks about a carryover effect may blur possible effects of the later treatment periods, and based on the present results, caution should be observed in the interpretation of crossover study of ginger extracts. Conclusions, no toxicity reported in any clinical trial or lab routine. Reported adverse effects were mild for ginger. Prostaglandin, leukotriene, possible reasons for this ginger working as an analgesic. Delayed therapeutic action in trials, and no evidence of short-term efficacy of acute pain. All this, again, could have been substantiated in conclusions along with the scope of study. And again, major analgesic agents are coming up. Those things can also have been included in the conclusions. Coming to scope of the study, placebo controlled triple-blind 3-period crossover trial can be used for methodology enhancement. 24 hours full mouth debridement parallel study for analgesic effects of ginger. Now this is another reference, beautiful reference from our Shastras, where we find that Kundrishka Churna or Bushvilla serrata Churna is useful as an external agent and with proven analgesic activity. This is direct reference from dental diseases in Ayurveda. Drugs like Syzygium aromaticum, Jasminum grandiflorum, Phyllanthus acmella can be tested in a similar way, which are usually used as folk medicine for controlling dental pain. My sincere thanks. When I talk about thanks, it is never enough. I certainly believe that Girish sir was the one who actually, sat me down actually for many draft presentations, and it was he who taught that it is certainly not bad if you have not included certain things and methods, but it is certainly bad if you've not written it down. So Girish sir, thank you so much. And Dr. Supriya Balaram ma'am, she was there for a few sessions in spite of her busy schedule. Her encouraging words and her absence actually was more felt than than anybody else rather. And Dr. Kishore Patwardhan sir, again, Professor Department of Kriya Sharira, he was there talking to us how to proceed and how the presentation can be made better. And my sincere thanks to Dr. Charu Sharma. She is one soul that we can always see to, and she everybody stumbles when it's the process of doing a new thing, and she takes you through the entire process. Dr. Maitri, analogous to her name, she's very friendly, and she again guides you. She tells you important things and how the presentation can be put, and she makes it very, very easy for any presenter. Dr. Vinay sir, for having written down many important points that needed changes actually. Thank you, sir. Thank you. Thanks a lot for all the team, JAM team, for enriching the performance and the presentation. And also special thanks to Dr. Samir, who in fact shared last minute points that could add value to my presentation. And Dr. Ramano, sir, he always says that, it is not just enough to be meticulous with research. It has to be, even an inconvenient truth can be said with beautiful, not hurtful words. And I thank Dr. Shiv Balaji, who stood and gave me the space and time for doing my project and to come to its completion. Dr. Sushma ma'am, I thank her. It's her love and care is more like a mother to a child. I don't have words to thank her. Ms. Shailaja ma'am and Dr. Prilada ma'am for their exclusive inputs in terms of the drug. And Dr. Unikrishnan B, he's a statistician. He's got his PhD in Poisson distribution. He in fact sat me down and told me what exactly pairing of data and how it could improve the p-value, and how this paper could have been more better. And certainly Mahadevan sir for telling me, talking about ginger and how it's like the half-life and everything related to it. I thank my heartfelt thanks to all. I acknowledge them. My heartfelt thanks for all. And Dr. Pallavi Menon, she spoke at large about how difficult her study was, how she had gone through, how she's meandered through various studies. And she also told me that it was like a real life situation, which involved, meeting with patients who are ready to take ginger, in fact. And special thanks to her also for spending time with me and talking to me about this paper. Thank you, madam. Thank you. Thanks a lot.
Thank you, Dr. Reshma. Thanks a lot. It was a wonderful, wonderful presentation. You had taken so much of efforts to do such a critical appraisal, give it such good constructive criticism to the authors and the papers, such a wonderful dissection. And you have talked wonderfully about the confounding factors, the bioavailability of the drug, how it may affect. So thanks a lot. Thanks a lot for your presentation. Moving forward, I would like to invite one of our expert panelists, Dr. Samir Jadhav sir, to give his expert opinion and comments. Sir, please. Samir sir.
Thank you, doctor, for inviting me, but I think it's an honor and a respect of the first author. Dr. Pallavi should speak first because she is the main person because of whom we are all here. So I request Dr. Pallavi to speak first.
Thank you.
Yes, sir. Yes, sure.
Okay.
Dr. Pallavi Menon, ma'am.
Yes, good afternoon. I'm really happy, that this study was selected by Dr. Reshma. It was a very wonderful presentation, and I've already appreciated her before for the effort she has put for this. She has done a lot of research, and it was a very, eye-opener for me as well. So I think, if I had met her before the start of the study or even during the study, I could have actually improved the paper. So it was a really nice presentation, and thank you so much for choosing my study.
Thank you.
Thank you, madam. We congratulate all authors of this article who conducted this clinical trial. Actually, crossover study design is very much complicated in terms of planning, execution, statistical analysis, as well as interpretation of results. And you have done a commendable job, madam. Thanks a lot. And thanks a lot for helping Reshma also in this presentation. Thank you. I would request Dr. Samir Jadhav sir to give his critical comments on this presentation.
First of all, I would like to congratulate Dr. Reshma for doing a wonderful presentation, and she really changed the whole perspective of the study and the study design. Right? I wish you could have been a dentist, and we would have enjoyed this presentation more in detail and elaborative way. So good. Thank you very much for presenting this. And Dr. Pallavi, even the study which you have done is really good. and slowly such kind of studies which needs to be done in our field, so that more and more people will start using our Ayurveda and traditional medicines in the mainstream dental practices also.
Yes, definitely, sir.
There are a few queries I would like to ask you.
Okay.
One is why you chose ginger when we have other Ayurveda indications for anti-inflammatory indications.
First of all, for the availability, that is because of the time period that was allotted for me to do the research was very short. So I had to find out something that was commercially available. So I wanted to compare the commonly prescribed ibugesic with an alternative drug. So that's when I came up with studies that have compared this effective ginger on pain, comparing it with ibuprofen. So yeah, so that is why I chose ginger.
The same question which we had discussed, that there were no pre-medications given to any of the patients. Generally we give, because when patient comes to us with some complaint, we treat him, right? We do the scaling and polishing, and that time we prescribe him something. But for the study purpose, you never gave them anything, or you don't follow it routinely?
No. Periodontitis is usually it's a chronic form of it is a chronic form. So usually patients do not complain of any acute pain, and even if they do, it will be in their in the first dental visit, which at which we wouldn't be doing a flap surgery. So usually the gingival inflammation should have been subsided by the time the patient is posted for surgery. So all the other acute conditions like any pulpal involvement, which is usually why patients come up with pain. So that is when, that would have been already corrected by the time the patient is posted for surgery. So at the time of surgery, the patient is not in any pain. And so we really did not require any pre-medication before the surgery. No analgesic or antibiotics are usually prescribed before the surgery in case of chronic periodontitis.
But there are some patients who are anxious, or those who are worried about the dental treatment or a surgery when you're talking about the flap and a flap surgery. So we need to give them something to pacify them. So what you had used for such cases?
No, see, flap surgeries are usually done under local anesthesia. So it is not a painful procedure at all, except for the pain of the while injecting the local anesthetic. Other than that, usually the patient is not under pain. So and it is done on the dental chair. It's not done in the OT or a hospital setup where the patient is usually anxious. On the dental chair, it is done like a common dental procedure, like a common dental extraction. So usually most patients are not that anxious that we actually require a pre-medication for that. Only the injecting the LA will be a painful procedure, for which we use a pre-topical anesthesia, so that the patient doesn't feel much pain while the needle is injected. So we just apply a topical anesthesia in the gums, and then the anesthetic is then injected in those areas.
Anything else you would like to comment about the study design?
Anything else, as in definitely, Dr. Reshma has already pointed out all the limitations and all the drawbacks of the study. So yeah, I wish I could have corrected it at the time of my study. But otherwise, like I said, in the short period that I was allotted for the research purpose, this is what I could do. So I hope I have done my best in the time that was given to me. But yeah, otherwise I could have improved a lot if looking at the drawbacks that was already mentioned by Dr. Reshma.
What made you choose that 400 milligram of ginger to use as an anti-inflammatory against the 400 milligram of ibuprofen? How could you reach to that point that they both are equivalent and then they should be compared?
Yeah, there are previous studies where they have compared ginger in the form of capsules, and they have used 400 Yeah, they have used 400 mg, I believe, but it's not the same company that I've used. It is some other company, but then it was again 400 mg capsules. And and the one that was available here in the local Indian market that was given by Himalaya was again in the same dosage. That is why I chose 400 mg. There's no other particular reason why I chose. In the previous studies, all the commercially available ones were in the range of 250, 400, 1 gram, etc.
Right, because when you talk about 400 milligram of ginger powder as a tablet, then the gastric irritation is the very common question. Yeah.
Okay.
A common limitation. So how did you overcome this in your study?
I'm not too sure about the gastric irritation caused by this particular dosage, but then none of the subjects in my study had reported of any such adverse effects. And I guess in the previous studies also, there was no such an adverse reaction that was said, especially the one on the dental pain model, where again they have compared the ginger capsule and ibuprofen. So in that study as well, there was no particular gastric irritation was mentioned as an adverse reaction. And yeah, so I did not confound that. I mean, I did not consider that as a adverse reaction in the study.
There's one question in the chat box for me. How do we take this as a dental practice, regular use in a dental practice? It's a very good question, or I say suggestion, or I can take it as a compliment, or we can take it as a indicator also, right? Because the traditional medicines and the Ayurveda recommended practices are not so common in our conventional dental practice because we were never taught about it. And sometimes it happens also that once your patients are not, once your doctor is not convinced, how can you convince your patients to consume the same? But now it's an increased trend in the practice that so many people are using the traditional medicines or Ayurveda medicines or home remedies into your day-to-day problems. And they come and ask us, doctor, do you have something rather than medicines, or can I use something else because I'm already on different drugs? So definitely this is a very good option, ginger, to be used as a routine dental prescription. But again, the gastric irritation and other systemic conditions, which are very common when you are trying to prescribe this as a medicine. So we need to take those confounders also into consideration before prescribing this as a routine prescription to our dental patients.
Okay, doctor, I just had a doubt, like this is present in the form of capsules. So it is not like directly the dry ginger powder is taken by the patient, right? So the capsule can act as a protection for the gastric irritation to an extent, I feel.
Yes.
I'm not theoretically, I'm not too sure
that's
about
the advantage
it,
of making the capsule out of it.
Yeah.
But again, when you say about capsule, again, that capsule has to go in, and that taking in capsule also is not so easy for small kids as well as for senior patients.
Yeah.
For the middle age, yes, they can directly pop it out, but the limitation comes when you talk about the young
prescription
kids
and
the senior citizen, because again, that big capsule against to consume is again difficult.
Difficult, yeah, I understand.
There is another way which you can mix this ginger and use it in your day-to-day practice, but that has to be, again, needs to be validated because there are no studies on that. You can mix them into honey and take it early morning. It will work much better when you, as per the Ayurveda recommendations, that when you have a kapha related problems, that is above your shoulder, if you have some problems, and if there needs to be any herb has to be used, if you use them early morning, empty stomach with the honey, it works better. But again, maybe this is a new study. Everybody can think. If anybody can start working on it, it will be good for us, and it will solve the problems for majority of the people.
Thanks a lot, sir. As Dr. Pallavi madam said, that if we use capsules, then the problem of gastric irritation will be taken care of. But Dr. Sapneem Bursi is asking that no, that's not possible only if capsules are enteric coated. So, Dr. Pallavi, can you throw light on this issue?
Is the entry coated?
Yeah. He's
Yeah,
asking that.
I believe it is entry coated. I'm not too sure about it. So, but as I remember, it was mentioned on the package of the Himalaya drug that it is entry coated capsules.
Okay. Okay.
I'm not too sure about it. I need to cross check again. Yeah.
Okay, madam. Dr. Ramakrishna Shenoi, sir, who was the expert panelist for this journal club, will not be available for critical comments and concluding remarks also, as his flight is about to take off now. So he has informed us about this. There's one question for one question for the author. Dr. Pallavi madam will can answer this question. What motivated them to undertake this study? What motivated you to undertake this study? Pallavi madam.
As I had mentioned, I was looking for an analgesic in the alternative medicine because ibugesic has a lot of it is contraindicated in many patients, especially those with asthma. And also it has side effects. Like most of the allopathic medicines, they have the side effects of causing gastric irritation, gastric ulcers. So again, that is contraindicated in such patients. So we always find it difficult to prescribe a medication for dental pain or even after surgery. So after surgery, we definitely have to prescribe an analgesic. And in some cases, when the patient has gastric problems, as well as patients who are asthmatic, we always, find it difficult to prescribe medicines in the allopathic medicine category. So I was looking for something in the alternative medicine which has lesser side effects and something that can be prescribed to such patients. So that is how I came up with studies where they have compared ginger with ibuprofen, and that is how the study was undertaken.
Thank you.
Dr. Pallavi, any Ayurveda physician was there when you were planning the study, or when you were enrolling the participants into the study?
No Ayurveda
As a
physician.
co-investigator?
Yeah, because
No.
as Ayurveda dictates that there are three categories of individuals. For some people, ginger can be mild irritant also. So there were chances of getting hypersensitivity reaction or hyperacidity reactions, or maybe indigestion.
Okay.
Or in some cases, there are chances that the heart rate can also go high. So were considered at the time of enrolling the participants into the study?
No, allergy was mentioned to the patient. We had asked all these subjects whether they were allergic to ginger or any forms of ginger. But then, that was excluded. But no, I had not consulted an Ayurveda physician for the same.
Okay.
Any questions from the audience? Please put them in the chat box so that we can discuss it here.
There was a question from Dr. Sai. They are conducting one split mouth study for his PG student. Comparison of local drug delivery for general periodontitis with pocket depth less than 5 to 6 millimeter with aloe vera plant extract and probiotic drug. They want to know how to calculate local drug delivery pharmacodynamics in this. If they is not control or sustained release. Please clarify about this. The question is there in the chat box.
Yeah, Dr. Swapnil, can you comment on this?
How to calculate local drug delivery pharmacodynamics?
So generally, we use the sublingual route of administration of some of the drugs. But when you're talking about the inside the pocket, that is the gingival pocket, then there are very limited medicines which are available, which are routinely used and practiced. So we need we really need to look into it, and then only we can comment on it.
Okay.
Dr. Swapnil Borse, can you comment on this?
Yes, can you please repeat?
Yeah, the question is there in the chat box, sir. They are conducting one split
Hello?
mouse study for their PG student, comparison of local drug delivery for general periodontitis with pocket depth less than 5 to 6 millimeter with aloe vera plant extract and probiotic drug. They just want to know how to calculate local drug delivery pharmacodynamics.
Okay, so for calculating the pharmacodynamic drug delivery, I mean, so pharmacodynamics is different and drug delivery calculation is two, this is a different. So there is a cell called distribution cell. So in any pharmacy college, it can be available, and the local site which you are targeting, that can be tested. There are the two compartments, and you can check the drug delivery using HPLC methodology or UV spectrophotometer, depending on the drug. So that that way you can understand the drug delivery, whether it is happening or not. And in terms of whole system kinetics, you can also assess the blood at a different time interval to check whether the drug is reaching to the systemic circulation or not. And on another front, for the assessing the dynamics, we have to assess at the phenotypic level. Hello?
Okay, okay, sir. Thank you. Thanks a lot. And your
Okay.
critical comments on this paper also.
Yes, thank you. Thank you.
Thank you, Dr. Swapnil.
So there are no more questions. Dr. Yogita Jamdade, do you want to ask any question, madam? Dr. Yogita Jamdade, madam, you have raised hand. Please unmute yourself.
No, sorry, Dr. Vinay, it was by mistake.
Okay, okay, no problem, madam. Thank you. So there are no more questions in the chat box also, or question answer box also. So I would request, I think, first of all, I would like to congratulate Dr. Reshma, Sanil for the wonderful presentation. I think the presenters of JIM Journal Club are raising bar for further presenters also, and that's commendable. Dr. Girish Tillu, sir, do you want to say anything?
Nothing specific. Nothing specific.
Okay. So I would request Dr. Samir Jadhav, sir, for the concluding remarks.
So, as a clinician, Dr. Pallavi has done a good survey, good study also. And as she said that it is not so easy to get the clinical participants with everybody's limitations and acceptance level to participate in the study. But considering all these things, then convincing them for doing a flap surgery, and when they say yes, then using the alternative medicines or the traditional medicine or Ayurveda based medicine for the same. So I would really congratulate Dr. Pallavi for a good initiative, and this will really open up new venues, and new researcher will also start doing similar kind of study. And definitely with the presentation of Dr. Reshma, we as a dentist will also start doing more clinically refined, and structure wise also we will refine our project and then start putting up as a clinical trials.
Thanks a lot, sir. We
I would
invite.
really like to thank the CCIH team and the team from Amrita Dental College and Pharmacy College for coming up with such a good presentation.
Thank you, sir.
I'd really like to thank Dr. Girish personally because for inviting me to this and the whole team of CCIH.
Thank you, sir. We invite participation from PG students, researchers, faculty as a presenter for next journal clubs. If interested, please email your interest along with a statement of intent and 3 articles of your choice to editor.jim@gmail.com with the subject line as participation in JIM Journal Club. So this is a request to all participants here. So certificate is issued to Dr. Reshma Sanil for the wonderful presentation. You can watch this presentation. You can go through the presentations of previous journal clubs and this journal club also on our YouTube channel. The link is shared in a chat box. You can go through it also. And so coming to the end, so certificate of participation to Dr. Reshma Sanil. Congratulations, Dr. Reshma. So at the end, we are thankful to expert panelists Dr. Ramakrishna Shenoi and Dr. Samir Jadhav sir. We are very much grateful to Dr. Pallavi Menon for giving her inputs on the paper and for welcoming the critical comments also. Thank you, madam. We are thankful to CCI's technical team, and before that, I would like to congratulate and I'm thankful to Dr. Reshma Sanil for this wonderful presentation. Thanks to Dr. Maitri and the technical team of CCI. I'm thankful to Dr. Girish Tillu sir, Dr. Kishore Patwardhan sir, Dr. Supriya Bhalerao madam for guiding us in this event. Thank you. Thanks a lot. Thanks to all. So I would declare that the meeting is over. Thank you.
Thank you, sir.
Yeah, thank you.
So, thank you.
Thank you. Very well
Namaste.
done, Dr. Reshma Maitri.